Dear Facebook Pure Urology viewers, as you all know, good evening everyone. Like every day we are discussing, or alternate day we are discussing about the surgical techniques related to the urology. As you all know that shockwave lithotripsy is still considered as one of the uh, treatment modalities of choice. Even in EAU and AUA guidelines, less than 10 mm irrespective of the location, except in obstructed stones or lower ureteric stones, it is the treatment of choice, both AUA and EAU guidelines. Not only that, in children it is very effective. So today we are discussing about the ESWL. Where are we? At this stage, what is the current role of ESWL? Is it that FIRS and PCNL have changed the scenario? So that we wanted to discuss today, and our and so to discuss that, I have invited Dr. Amelia Pietropaolo from UK. Actually, she was introduced by Dr. Mohsin today to me, and fortunately, when I was talking to Dr. Bhaskar Somani, he also appreciated they worked together with Bhaskar Somani, and she has done lot of work on ESWL. And because I don't know her personally, I will directly ask her certain questions about her career, and then I will introduce her CV, and then we will hand over the program to her. Madam, good evening. Thank you for accepting the invitation. Your kind immediate response for Dr. Mohsin as well as to my mail is highly appreciated. To be precise, we don't know the educational system. What is there in UK? Which country you belong to, madam? Primarily UK?
No, Nancy, first of all, thank you very much for the invitation, for you, Dr. Mohan and Dr. Mosi, to have invited me to this fantastic opportunity of a pure live streaming webinar. So I work in the UK now, but I've actually trained in a different system and in Italy. So I come from Italy, I was born there, and I
Okay.
studied my medical school, and my residency, my training was done in Italy.
Okay. After you completed your medical school, you how did you develop interest in urology, or are you there in some other departments and then you came to the urology department?
Yeah, I was still looking for what was the best specialty, and then I ended up in the urology department without knowing exactly what this was, and I found it was very interesting. So I initially found interest in urogynecology, but then quickly during my years in the urology training, I developed interest for endourology and urolithiasis.
Okay. In your day-to-day practice, what constitute majority of the surgeries in your OT related to endourology?
So in my personal one is mainly ureteroscopy,
Okay.
kidney stone, intrarenal kidney stone treatment, and PCNL as well. But ureteroscopy probably is the most the main one that I perform.
We observe that last 2 decades the size of the stone detected in the patients irrespective of the age has decreased because of over usage of the ultrasound. Is it the same in your country, in your practicing place?
Yes, it is the same. Yeah, also CT scans. And we use a lot the CTKUB as a diagnosis. Main first diagnosis for us is the CTKUB. So there is very often the case of an incidental finding of kidney stones while other pathologies are being investigated, and therefore it happens that much smaller stones comes to our way to get treatment. So yes.
So before last question, before I hand over read your curriculum vitae, predominantly when you see a patient who has stone less than 10 mm in the kidney, what your mind says at this juncture, when you are good at flexible ureteroscopy, when you are good at ESWL, you have the best mission for ESWL, you have the best technician, you have the best ultrasound. At the same time, you yourself is best at first. How will you choose the patient?
So in this country and our state of mind is that we normally go through every procedure with the patient, including ureteroscopy and lithotripsy, and we just tell them very clearly what are the risks and benefits of every procedure, and because the indication is similar for both in case of 10 millimeter stones, then we let the patient decide, explaining very clearly which are the benefits of the two procedures. But in my experience, lithotripsy in this type of stones has a very good efficacy.
Okay. So thank you very much, and I will share officially your CV. Dear viewers, Dr. Amelia Madam is currently working as Associate Specialist at the Urology Surgery Department, University Hospital, Southampton NHS Foundation Trust. Her field of interest is urolithiasis, endourology, and minimally invasive surgery. She is the chairwoman of YAU Urolithiasis and Endourology Working Group since 2020, Young Academy Urology Group, part of EAU. Member of Youth Editorial Board of Journal of Minimal Invasive Surgery. Member of ENI US, European Network of Multidisciplinary Research to Improve the Urinary Stents. Member of the ITRU Group, International Training and Research in Uro-Oncology and Endourology Association. She is also an active member of the STONE team and plays a vital role in the investigation, screening, operative procedures and follow-up of these patients. She is also dedicated to research and is the clinical lead of the lithotripsy service. Her most recent publication is Safety and Efficacy of Daycare Percutaneous Nephrolithotomy, a systematic review from European Society of Urotechnology. Best paper from literature ULIS 2017 with role of simulation in urolithiasis intervention, URSL and PCNL. Clinical Research Award ULIS 2019 with endourological management PCNL of stones in the solitary kidney. That is an excellent academic career at an younger age. It obviously shows that you are the chairwoman of YAU Urolithiasis. I really appreciate the amount of the research you are doing after you did your medical school from Italy. You are really working hard for the endourology and urolithiasis. Thank you for accepting the invitation, Amelia Madam, and I will hand over the program to you. Please feel free for the time and explain the cons and pros of the SWL. Thank you, Madam.
Thank you for this kind presentation. I'm gonna share my screen so we can all have a look at my presentation. That's my presentation. Yes. And again, thank you to Pure Urology for this invitation. So, as discussed before, my name is Amelia Pietropaolo. I work as an associate specialist in endourology, and I'm a chairwoman of the YAU Academic Urology Group, which is a young group inside the European Association of Urologists, and this is mainly in the endourologist working party. And I come from University Hospital Southampton in the United Kingdom. I'm very pleased to be here with you today to discuss about the current role of shockwave lithotripsy. So first of all, I wanted to start with a brief introduction. So SWL, as we know, is the energy impulses that called shockwave. They're used to treat renal and ureteric stones, fragment the stone in order to be small and easy enough to pass, and they can also be used for different conditions, for example, gallbladder stones or fasciitis. But what we use them in urology is to apply an extracorporeal, that's for a minimal invasive shock wave, so which is an acoustic pressure wave, to a stone, and therefore is called lithotripsy. How does it work? essentially the shock wave are normally generated by a cylindrical source. This is inside an aqueous environment and is focused by a reflector that causes them to converge and to precisely target the stone. So the shock waves are induced by this cylindrical source, and they go through this coupling cushion in a diaphragm, and the coupling agent is able to let them travel around through biological sources, tissues, and the shockwave will then encounter the stone. And once the stone is targeted, the compressive and tensile stress lead to formation of cracks in the stone. Repeated shocks in the stone will allow it to break into small bits that will then be able to come out spontaneously. So the technique is sometimes very complex, but it's very easy to understand that the shockwave creates a bubble of energy that travels through the tissue, and in particular in this case through the stone, causing collapsing of it in an asymmetric way in order to cause a change of impedance of the stone's interface. The aim, as we said, is to make sure the stone, once broken, can pass through spontaneously through the ureter, the bladder, and the urethra, of course, trying to, of course, not causing too much pain. Generators are of different types. The principal, so the one that are most used, are the spark gap, the piezoelectric, and the electromagnetic. However, also the electrohydraulic was very much used. You can see here some examples of them, mainly the piezoelectric source and the electromagnetic source with flat and cylindrical coil. All devices of this current generation use water cushions with coupling membranes to transmit the shock waves. These are examples of comparison between old and new generation lithotripser. As you can see, the first lithotripser was created and used in 1980s when the patient had to be fully covered in water to be treated with lithotripsy. And one of these lithotripsy was still in action until a few years ago. And now we are going towards a much more technological example of lithotripsy device, which can use modern technology, small screens, and remote control to treat our patient stones. The generator that we normally use is the electromagnetic generator. Most people use the piezoelectric as well, but in our experience, we use mainly electromagnetic source. This is the source of the shockwave lithotripsy that originates from a cylindrical coil, and then the shockwaves generated are reflected from a surface and focused in a single one point. There is a free space underneath the cylindrical coil which allows to insert the ultrasound probe that can help in targeting the stone, that sometimes can be targeted with X-rays, some other times can have a combined targeting ultrasound and X-ray guided. And this is how it works. So from the generator, the wave travels in the biological tissue until hitting the stone. In this patient, the patient position is more or less this. However, not all the stones are visible, and we normally use CT KUB or X-ray KUB in order to locate the stone and the location. And these tools can allow us to say also if the stone is radiopaque or radiolucent, work out the skin to stone distance, and measure the Hounsfield units in order to confirm the indication for lithotripsy. But not all the stones are easy to see. This is how we target it. So in lithotripsy, we can use either fluoroscopy or ultrasound to target the stones. And this is an example of how the crosshairs can see the stone from, and this is originated by the therapy head, and allows to precisely target the stone throughout the whole length of the procedure. This is an example of how the focusing of the shock wave reach the stone, and it's a bit complex to explain, but eventually adjusting the stone in the center of the focus can allow, and the turning the X-ray head 30 degrees can allow the stone to be at the center and the depths to be on the right level for the treatment to be focused on it. What is coupling? So essentially the mean in which the shockwave will need to travel is an aqueous solution, and this needs to be free of bubble. Why is that? Because being full of bubbles or even a small bubble can decrease the energy level and give a suboptimal treatment. So it's very important that all the air contained in the solution is removed before starting the treatment, and this needs to be very well observed and followed during the treatment. The ramping is a technique that has been found recently, but has been shown to have very good results. This means that the energy of the treatment starts low and then gets gradually progressive augmented, and this is considered at the moment the best practice, because this can cause a vasoconstriction of the renal vessels, leading to renal stiffness and decreased blood flow. So this doesn't change a lot in terms of outcomes and stone-free rates, but the good difference is in terms of perirenal hematoma, because causing vasoconstriction will decrease the incidence of post-lithotripsy perirenal hematoma compared to how it would be if the energy would be increased suddenly. So our practice is to follow specific guidelines for shockwave number, frequency, and energy. So commonly the upper limit to deliver shockwaves is from 2,000 to 4,000 shockwaves. And there is no clear-cut recommendation. However, it's not advised to continue to treat if the stone is not disintegrated after 3,000 shocks, and equally is not advised to continue after visualizing the stone is already disintegrated. The energy recommended is from 60 to 90, and the frequency needs to be between 1 and 1.5 hertz for adults. Energy for children needs to be lower, of course, and is suggested to be 60. Clearly, as we said before, according to the ramping technique, the level of energy should be dynamic and change during the procedure, adapting also to the stone level of fragmentation. Also, the protocol depends on where the stone is located. So in our experience, we tried different shockwave numbers according to where the stone was. But eventually, we've decided that our guidelines is that for a stone located around the kidney or the PUJ area, which is very close to the kidney parenchyma, the patient will not receive more than 3,000 shocks with a maximum frequency of 1.5 Hz and an energy of 60. Instead, a ureteric stone, which has less risk of bleeding and hematoma formation because there is no surrounding parenchyma, we can give the same number of shock waves and 1.5 Hz, but with a higher energy that can go up to 70. Of course, lithotripsy in comparison to ureteroscopy has been found to be a very good technique as a first-line treatment options for ureteric renal stones, and this has been recognized as engraved and NICE guidelines. Also, its cost effectiveness has been compared, considering that lithotripsy can achieve the same stone-free rate of ureteroscopy with possibly multiple sessions, but on balance, the total cost with ureteroscopy sometimes can be higher because of the consumables, and the very high cost scopes. However, treatment for ureteric stones is still not optimal, at least not in the UK, because for emergency stones there is much more insertion of stents or ureteroscopies for stones compared to how many lithotripsy we're doing. And this is why we're trying to change the things. And in fact, in the last few years, and mainly this is a paper just published, there is a non inferiority study between lithotripsy and ureteroscopy. This has been done in a multi-center pattern and in a randomized control non-inferiority trial that found that SWL can be considered non-inferior to ureteroscopy, and in fact the stone-free rate is equal or higher in ureteroscopy in SWL compared to ureteroscopy after 8 weeks of treatment. NICE guidelines have in fact introduced SWL as first-line option for kidney stones less than 10 millimeters and also for kidney stones between 10 and 20 millimeters at the same level with ureteroscopy. SWL has also been in the first choice in ureteric stones less than 10 millimeters, and for ureteric stones between 10 and 20 millimeters to be considered if the hospital in particular has the facility to achieve a stone clearance within 4 weeks for this bigger size of stones. For example, doing a strict follow-up and trying to retreat in case this is not stone-free after the first treatment. Also, the timing of the surgical treatment has been found to be paramount, and for urgent treatment for ureteric stones and patients with renal colic has been found that treatment within 48 hours should be the way forward. In particular, the patient cannot tolerate pain, or the stone is in a position or a size that is unlikely to pass. So lithotripsy has a great future still and is not dead, as somebody may have thought. Also, EAU guidelines have considered lithotripsy a lot in their guidelines, in particular for stones less than 10 millimeters in the kidney, but also between 10 and 20 millimeters, while for higher, bigger stones, this is not the first choice, of course. For ureteric stones, there is a difference between proximal and distal ureteric stones, and of course, for smaller stones, lithotripsy is the first choice in both distal and proximal ureteric stones, and for bigger stones is still considered the same level of ureteroscopy. But many studies are being conducted about lithotripsy and its effect, mainly used in emergency. For example, acute extracorporeal shockwave lithotripsy as opposed to delayed one in obstructing ureteric stones. And there are many trials that show that the result of an early lithotripsy in obstructing ureteric stones can achieve very good outcomes and prevent possible complications. But what can affect the stone-free? So we need to discuss first of all about Hounsfield unit and skin to stone distance. As we said before, the stone attenuation and the skin to stone distance are very important parameters that may influence the shockwave success. So when the stone has a more than 1000 Hounsfield unit and the patient has a high skin to stone distance between 10 and 10 centimeters, there is a worse outcomes in terms of stone-free rate. So the number of shock waves required are also directly correlated with the stone attenuation value. And this Hounsfield unit can normally be measured by the CT together with the skin to stone distance. For stone location, very recently there have been a lot of studies trying to predict the success of lithotripsy for lower pole stones, because clearly this location is not favorable for stone passage. However, if a lower pole has a degree of a infundibulopelvic angle more than 45 degrees and a length less than 2.5 millimeter and a width more than 5 millimeter, there is still a good chance that the stone can pass through after lithotripsy. So it's important to consider all these parameters before deciding for indication or not for shockwave lithotripsy. And in fact, as the EAU guidelines have specified, for stones between 10 and 20 millimeters in the lower pole, if there are unfavorable factors for SWL, it's better thinking about ureteroscopy instead. The hardness or the composition of the stone is very important because hard stones will not respond very well to our shockwave lithotripsy. Unfortunately, though, most of the time it's impossible to predict which type of stones we're treating unless the patient had stones before and we know the type of the stone is used to form. For example, calcium hydrogen phosphide like bruchite, cysteine, or calcium oxide monohydrate stones are very hard and more resistant to SWL treatment. Hounsfield unit can help in these cases because this type of stones very often will have a Hounsfield unit attenuation higher than 1000. And this, in fact, how a recent study have shown what are the predictors of success following extracorporeal shockwave lithotripsy in a contemporary court. This is just a paper of last month. And they've analyzed many patients and their multivariable analysis showed that between all the parameters they have analyzed, mainly stone size and skin to stone distance were the independent factor for SWL success. So as we said before, a stone less than 10 millimeter and a skin to stone distance less than 15 centimeters have a very much higher success of stone-free rate. Complications of shockwave lithotripsy. As we said, there are what they need to be considered, in particular where we counsel our patient, where we go through pro and benefit of the treatment to compare it with other treatment we can offer, such as, for example, ureteroscopy. And the side effects, which are very common and mainly normally self-limited, are blood in the urine for a few days, pain in the kidney area, UTIs, mild bruising of the skin or blistering of the skin where the machine is applied to the skin, or needing for further treatment, or needing for different type of treatment in case the treatment is not achieving a stone-free rate, or Steinstrasse. Less common side effects can include severe infection as sepsis, required admission intravenous antibiotics, and in our case serious, this is very, very low. And the renal hematoma, unfortunately, is consisting for 1% of the cases, but when there is, we need to be very careful to follow it up correctly and possibly not repeat lithotripsy on the same area for that patient. Obstructing ureteric fragments can occlude the ureter and causing hydronephrosis and pain. This can happen very commonly. Sometimes we can just treat them again with lithotripsy, but sometimes when the pain is refractory to painkillers or infections occur, there is a need for further treatment, for example, emergency double J stent insertion. Recurrence of stone is, of course, one of the known complication of kidney stone formation. And I wanted to introduce you to our University Hospital of Southampton lithotripsy team. So we've got 3 radiographers and 2 specialist nurses. And in particular, the specialist nurses follow the patient up very strictly before and after the treatment. They make sure there are no contraindication and they make sure with x-rays that the treatment is working correctly. And we do constantly and regularly MDT to review our results and to discuss about the more complex cases that we're going to discuss later and show you some. Together, since we've opened our new lithotripsy center in 2019, we have changed our guidelines in terms of analgesia. So previously we used to do intramuscular pethidine, which is a very strong opiate during lithotripsy, and that was causing the patient to be very drowsy after the procedure, to not being able to to drive. And therefore we actually done a survey on Twitter to understand who was still using opiates for kidney stone treatment and lithotripsy. And actually more than 40% of the responders have shown that they didn't use any more opiates, but they actually used oral NSAIDs or PR diclofenac. We've then analyzed singularly every responses, and we understood that almost nobody was still using opiates, despite it was still in some guidelines. We've also checked the literature. In the last 10 years, there was a gradual change towards NSAIDs compared to opiates during lithotripsy. So we've therefore changed our analgesia protocol, and we've presented in a European Urology Association conference where we've introduced the PR diclofenac 100 milligrams together with 1 gram of oral paracetamol 15 minutes prior to lithotripsy treatment. We've then compared our results, and the VAS pain scale that was shown by our responders was a mean of 1.12, and most of our patients were very happy of our treatments. This has been associated also to the use of music in the outpatient setting. So, for example, music can help during lithotripsy and other endourological or outpatient procedures to reduce the pain, reduce the stress, help the patient to relax and require less analgesia. And this, if you can see it, is an example of how we treat our patients. So this is a patient who volunteered to be filmed, and we use during the treatment a radiographer follow the treatment all the time, and we use lights and sound in order to make sure the patient can relax and cannot think about the pain, but also will have a low painkiller requirement. And this is having very, very good results in our patients. And in fact, it's been shown by a systematic review how music and audiovisual distraction during shockwave lithotripsy can give a very good outcomes. Talking about contraindication about lithotripsy, as we know, there are many contraindications, and we need to be very careful, mainly of patients who have aortic aneurysm, ureteric stones that are causing obstruction and hydronephrosis, anticoagulants, uncontrolled UTIs, high blood pressure, uncontrolled high blood pressure, severe skeletal malformation or obesity that makes difficult to target the stone, pregnancy, or automatic implant defibrillators and pacemakers. Some of them we're going to discuss because we have challenged during our progression of treatment, we have challenged some of these contraindication, mainly pacemakers. So our lithotripsy is called Modulate SLK from Storz, and in our manual it just says that it's possible to treat a patient with pacemaker under precautionary measures. For example, the manufacturer needs to deem that the pacemaker is fit for lithotripsy treatment, and this must be checked prior to the treatment. And our manual just states that the treatment should not go ahead if the pacemaker is not cleared for treatment by the manufacturer. So this unfortunately created a big gap of our knowledge, and we didn't know if we were able to treat or not the patient with lithotripsy. Also, we were receiving a lot more of referrals from external centers because clearly COVID has prevented many people with stones to have ureteroscopy and general anesthetics. Therefore, we treated many more people with lithotripsy. And we had to have specific guidelines on this topic. For example, we've had some meetings with the cardiac management team of our hospital and understood how this works. So the potential damage is within the pulse generator. And of course, we need to be sure that the distance between our cylindric source of shockwave and the pacemaker is enough to prevent the damage of the pacemaker. So some pacemaker like Medtronic, they advise a minimum distance of 2.5 centimeters, some others 15 centimeters. So we need to be very careful which type of pacemaker our patient has. And in most hospitals, there is a team that can help in supporting this. This is an example of pacemaker that clearly, in this case, it would probably be less than 15 millimeters than a possible kidney stone. Our lithotripsy, as we said, is an electromagnetic source, and therefore there could be some interference, and the pacemaker can misinterpret that. And also the defibrillator can misinterpret that. This can lead, in the case of the pacemaker, to inappropriate inhibition of pacing, and therefore the patient can be at risk of bradycardia or pulses. Same thing can be for the defibrillator. If they detect different rhythm, they can suddenly inappropriate shock the patient. So if in case of pacemaker, if you're concerned that this can happen, we can use a magnet. This will stop the pacemaker to feel the external signals and will continue to pace at a fixed rate of 80 or 100 BPM, depends on the manufacturer. Will the pacemaker will also pace on a fixed mode, and in this way will not sense any intrinsic signal and will not inhibit the pacing. Once the treatment is finished, it's important just to remove the magnets, and the pacemaker will immediately resume its rhythm. And this can happen. It doesn't mean that we need to use a pacemaker all the time, a magnet all the time that there is a patient with pacemaker. But actually, it's very important in this case to monitor with a simple ECG lead the patient rhythm. And if we see if there is a bradycardia case, then we're gonna use a magnet to stop the pacemaker to feel the interference. For the defibrillator, this is even more important because the magnet can stop the defibrillator to feel possible tachyarrhythmias detection, and therefore the defibrillator will not work during the magnet is in use and will resume its normal work as soon as the treatment is finished, or of course in case of emergency. Anticoagulants is also a very hot topic. First of all, we sometimes come across patients with hemophilia, and this is not an absolute contraindication. However, monitoring of the patient before and after the treatment is paramount, mainly with the hematology group. In regards to proper anticoagulants, we normally stop at our practice aspirin and clopidogrel for a maximum of 7 days, mainly for kidney stones. And we also stop anticoagulants, for example, apixaban, rivaroxaban, and oxaban, for at least 48 hours before the treatment. This, of course, depends on the reason for anticoagulation. For example, if the patient had an MI with stenting or CABG or a stroke in 6 months previously, in that case, he needs an anticoagulant and he needs aspirin or clopidogrel, and therefore, if it's possible, it's better to postpone the procedure if this is elective. However, if this is very important and necessary for emergency, then a ureteroscopy under aspirin can still be performed. Similar things is about stopping anticoagulation in patients with active PE or DVT. In these cases, it's much better to think and consider alternative treatment options. And this is our lithotripsy Storz Modulith SLK. Our lithotripsy center opened just in 2019. Prior to that, we had only a mobile lithotripsy once a month that didn't achieve very good outcomes, in particular because we didn't treat patients with the right schedule and with a good regularity. So we've started with one patient, with one lithotripsy session a day, 1 day per week, and we used to treat only 6 patients at the beginning. Then we have increased because of a rise in emergency treatment and external referrals. We've increased to 3 days per week, and we're treating almost 20 patients per week from 2019 to now. And during COVID-19, lithotripsy service is the only thing that never stopped in our department because clearly it doesn't require any general anesthetics, and it's a day case outpatient procedure, and the patient can go home immediately after. Of course, with the care related to the case, but we managed to treat many more patients than before the COVID-19 time, and we received a lot of external referrals of hospitals that were unable to treat their stones, their patients with stones, because their operating theaters were shut due to COVID. So lithotripsy was actually the only way to treat stones during that 1.5 years of COVID-19 pandemic. Things are now better, but still we remain very busy. And that's how the patient gets referred to us. So mainly they have to have a proven stone in the CT. They need to be clinically well, so not shown any symptoms or sign of sepsis. They don't have to have any of the contraindication we have previously discussed. And in this case, once we receive the referral, we are able to deliver treatment within 48 hours if this is for obstructing ureteric stones. The referral forms that we ask the referral team to fill is actually a list of all the patient characteristics and contraindication, and we use this to understand, first of all, if there is indication, but second, if there is any risk for the patient to undergo our treatment. And this is the information leaflet that we give to our patient when there are all the specifics about the risks and what to expect after the treatment, but also which medication to stop. And this is very important because at the end of this leaflet, there are our telephone numbers the patient can call for any doubts, but also for any possible pain or or issues after the treatment. In our case series, in the procedure day, the patient have as discussed before, as mentioned before, paracetamol or diclofenac prior to the procedure. We always check urine with a urine test that the patient has no evidence of infection. If there are nitrates or leukocytes, we normally cancel the procedure, send the urine for culture, and treat the patient with the sensitive antibiotics before he will have the treatment. We, of course, consent the patient explaining the pro and cons of the procedure, and we make sure the patient is in a gown. After that, with the radiographers, the patient is going to lie on the couch, on the bed, supine or prone, depending on the stone location. The stone is targeted normally in fluoroscopy, but sometimes also in ultrasound, when, for example, stone is radiolucent. And some water is poured underneath the patient, and the therapy head was covered in silicone oil and brought underneath the patient in order to start treatment. Our schedule is for ureteric stones to treat the stone the day one. After that, we see the patient after 2 weeks for a follow-up X-ray. If the stone is still persistent or fragmented but still in place, we can do a retreatment on the same day, and this can be done up to 3 times. Same things for kidney stones, but the time length between one treatment and the other is normally 4 weeks in our case series, and these are our personal guidelines that we created over the years. And these are our example of our outcomes. As you can see, some stones are very visible in radio, in x-rays, and this is an example of a kidney stone that was completely treated with lithotripsy. This is a PUJ stone that fragmented into 2 pieces. They were both treated with lithotripsy until complete stone clearance. And this is our team with the 3 radiographers and the specialist nurses and our lights behind the machine. But last but not least, SWL will not end, and actually I'm expecting this will have a much higher, bigger role in the future. Why is that? Because there are some new technologies, for example, artificial intelligence, machine learning, that can improve the SWL efficacy. For example, the recent study can show that despite lithotripsy is still considered a dinosaur, this can actually still be improved. And in fact, artificial intelligence has improved with an algorithm to increase the hit rate approximately to 75%, reducing the number of shockwave missing the stone by approximately 67%, which means using new technology like artificial intelligence can increase our outcomes and improve our outcomes in SWL. Equally, artificial intelligence in the future can be used to predict the type of stone we've got in front of us and the composition of it, in order to tell us how many treatments this will be required to treat for treating the stone, and if there is indication for treatment. And this was my last slide, so thank you very much for your attention. It's very, very precious to be here with you today, and please contact me if you have any question or offer any opportunity for future discussion. Thank you very much.
Thank you very much, madam. What an excellent presentation. So crisp and very steady you presented. No up and downs. Very good presentation, crisp. I wanted to ask certain questions, maybe around 10 questions related to the SWL, and then we will close the program. The
Thank you.
first most important thing is in the stone management, we are using CT scan plane nowadays for management of PCNL and RIRS or URSL. Do you think that is enough, or we have to do IVP? Why? Because the route map is very essential for the fragments to pass down. There may be bifid system, there may be other things which can be missed easily on CT scan. What is your protocol before doing ESWL?
So before doing SWL, we normally need at least a CT scan, but very rarely we use a scan with contrast or IVP. For example, some patients who present initially with hematuria, they will have a CT urogram as a hematuria investigation. And if this scan will show stones, then it's easier for us to predict the exact anatomy and the stone location. But for patients who present with renal colic, is most of the time this is a CT with no contrast, and this is enough for us to then plan the treatment. But I agree with you, sometimes it's very difficult to predict the stone passage and sometimes impossible, and therefore when the treatment fails and we go ahead to do a ureteroscopy, we actually understand that there was a stricture, for example, or the ureteric orifice was very narrow, or there was a bifid system, or a specific anatomy that didn't facilitate the stone passage. So in these cases, I would agree with you that a contrast study may facilitate our prediction for stone passage. However, because of the higher stone X-ray radiation exposure, we are still not very keen to do it for every patient.
My second question, how what is the indication for the pre-procedure stenting in your cases? Do you stent in any of the patients electively before SWL?
No, so we don't have experience in this. We actually found that patients who are stented have less favorable outcomes because we found that the stents can in some way prevent the stone to move after lithotripsy, will absorb part of the shock waves itself, and also it's more difficult to follow up. So for example, we follow up the patient with x-rays, but sometimes in the simple x-rays it's difficult to tell if the stone is still there because the stent can cover or can hide the stone. Therefore, for this above mentioned reason, we don't treat the stones with stents, and if there is a stent, we normally go to ureteroscopy.
My third question, normally recent times the stone management is based on the volume also. Last 1 year, 2 years, we are thinking of the X into Y into Z is equal to volume of the stone. Do you
Yes.
think in future 1 into 2 into 1 versus 1 into 2 into 2 will make a huge difference for ESWL, or it will not make a huge difference like in PCNL? For PCNL it may not make difference because your ampulla sheath is also three-dimensional, whereas for FARS it is a huge difference. If the volume is more, it takes a lot of time, stone free rate may be less. Logically for ESWL also, high volume stone results may be poor. Any papers or any comment like future everything guidelines will be based on the volume?
I agree. And in fact, with my group, the Young Academic Urology Group, we are trying to collaborate with the Guidelines Office of EAU to create a standardized way to measure the volume because it's still very difficult to measure, and some centers measure it in different ways. So it's definitely going to be different and important to know the volume before SWL because will make a difference in decision of treatment and indication. And I think artificial intelligence in this will be able to help with algorithm and ways to probably to calculate the volume from a CT scan, for example.
Do you think that in the future, because the X-ray and CT, if the radiolucent stone is present, ultrasound plays a major role. Technician plays very crucial role in ESWL management. If the ultrasound and the CM in future can be controlled by the robotic technology, so that proper focusing of the waves to the stone can be done, like artificial intelligence I am asking, so that the unit will be arranged by the machine in such a way that least distance path as well as the maximum focus point will be onto the stone.
Definitely. This is why I say future for SWL is still very bright, because I'm sure that many of these technologies will help us to target better, to make sure all our shockwaves will be focused on the stones, and for sure that can be regulated maybe by robots, as you said, in the machine itself, and the technician will not need to target manually, but maybe just adjusting the patient characteristic and anatomies and the stone characteristic as well in a software that will automatically know what to do. So that will be interesting to see what the future
Right.
is.
You said in the first go itself that makes the difference. So it is not all the end of the SWL. It may be beginning, because again technology may come in and the stone free rate may increase. In children, when you do ESWL, because we don't have experience with children, we do FARS only. In children, do you give the sedation, or in very small children like toddlers or infants, do you prefer general anesthesia? What is your experience SWL in children?
So unfortunately, we don't have a huge experience in children, because because there is another center which is dealing with lithotripsy in children, but we know that in children they use general anesthetic. So this is probably a downside, because if you need to do a general anesthetic for a treatment that may require one session, so may require 2 or 3 sessions, then probably it's better to do just one general anesthetic and perform ureteroscopy. So for children, I think there's still something to improve to make lithotripsy a bit more valuable.
In malrotated and particularly ectopic kidneys, to what level, L1, L2, L3, L4, sacroiliac joint, what level you are comfortable in such a way that the head can be accommodated and deliver the shock waves to the stone? Do you have any experience in ectopic kidney, which is difficult to imagine because of the sacrum?
Yeah, you're right. This is very difficult and probably changes cases by cases, because some anatomies are more straightforward to identify the stones, but some others not much. Also because the bowels may cover the stone, and the fluoroscopy may not be able to detect the stone because of the bowels gas covering the kidney shape. So we don't have much experience in this, and to be honest, because there is no great outcome in view of the drainage, that sometimes also the drainage is abnormal in these cases, we prefer perform ureteroscopies.
Ureteroscopies. That's a very good answer. And last couple of questions. As you said, electromagnetic, piezoelectric, and all the different sources are available. For long years, Dornier has dominated the SWL mission industry. uh, what will be the future which can reduce the size of the cylinder, which can make it is more portable, and do you expect any source of energy be changed. Like we are seeing laser missions coming portable, we are seeing flexible scope becoming smaller.
Yeah.
Like that, something has not happened last 25 years in SWL much.
It's true.
Yeah.
It's true, but there are some new things gradually developing. I haven't discussed about this in my presentation just because it's not proven in a big case series yet, but there is something called burst lithotripsy, which
Okay.
is a very small probe that manually can be make put on the patient kidney and will be a sort of a small ultrasound machine, but will create shock waves from the ultrasound probe at the same time. So it's much smaller, and because it's a shorter distance and all the generator is in the small um, machine, it has a much more efficacy. In America, they're already trialing it and looks like they're having good results. So we just need to wait and see.
Yeah, great. So last question, Dr. Amelia Pietropaolo, for your excellent presentation. If I wanted to ask you a question, practical question, this is the last question of the program. If you have a solitary kidney of 12 mm in the inferior calyx, which is less than 1000 Hounsfield units, you are good in all. I have seen your CV. You are good in flexible uteroscopy. You have equal number of papers. You are good in PCNL. You are good in SWL, understanding the mission. If the patient is fit for all the three, not very obese, would you like to give a chance for SWL or directly go for other modalities? Solitary kidney,
Yeah,
no
that's a tricky.
contraindications. 12 mm inferior calyceal stone, not very acute angle.
Yeah, that's a very tricky question. I normally go always for shockwave lithotripsy, but in this specific case, we need to consider all the possible risks. So there is risk of renal hematoma in a single kidney that can be much more dangerous than in a patient with two kidneys. We need to consider that if the SWL is working, will work, one of the fragments can be not small enough to pass through, causing sudden blockage, hydronephrosis, and anuria, and renal failure. And therefore, I think for this specific case, I would speak to the patient very clearly, and unless they have a specific will to go towards lithotripsy, despite knowing the risks, I would otherwise suggest to go through ureteroscopy and
Ultrasonic.
clear the stone with one treatment.
Great.
Yes.
So, thank you very much, madam. I really appreciate the way you are conducting the research along with your team. Wish that before you become a senior team, you will become well known in the field of the endourology. And if I like to have a presentation, one more, maybe after 6 months, about the first for any specific surgical technique you want to focus, especially video based, because I have gone through your CV also. We will be very happy. This is a continuous program for all the viewers. This link will be there forever, so they can review. And today, in fact, it is a quick review of 40 minutes of the ESWL, which you covered all the basics very precisely. And in fact, you have gone little depth in the pacemaker point of view, and we learned a lot of points in the last 10 minutes, where you have gone into the depth in publications. And I mentioned about the even regarding aspirin, clopidogrel, the anticoagulants in relation to the SWL. I really appreciate the efforts you have taken, and I also thank Mohsin for taking initiative. In fact, I wanted to call him, but otherwise this is one-to-one program. Both of you has made this possible today. Thank you very much. I will be in touch with you, madam.
Thank you, and thank you very much for
Thank
the
you.
pure association to sharing knowledge. This is very important in this time. Thank
Yeah.
you for the invitation, Dr.
Thank you
Mohan.
very much. Okay, see you then.
Bye.